Welcome back, Power Up Endo Nation. We are here for our second visit of our 2-visit treatment on this lower molar, tooth number 19. This patient waited 2 weeks after her first visit, and now she's here for her obturation appointment after we've completely instrumented this case and placed calcium hydroxide. So she presented to the office. She had no symptoms. She was feeling much better. She no longer had that spontaneous throbbing, and her post-operative discomfort lasted for a few days after her appointment, which has now since resolved, and everything feels good. So I'm going to show you exactly how to run this obturation appointment in a very time-efficient manner, and how we go ahead and finish this case. These appointments we book for a half hour, but oftentimes we spend more time chit-chatting with the patient than anything else. So we're going to anesthetize the patient in the same exact fashion that we always do with our Gaugates injection, which is a modified mandibular block that I talk about. And this is our working length radiograph from her last appointment that I always have my dental assistant place up on the screen, so I can just kind of recall the case and make sure there's no additional modifications needed to the working length. But 99% of the time, our working lengths are solid and they're the same. We're going to keep them, and we're just going to go ahead and actually instrument and use a rotary file, only the last rotary file that we instrumented to. So in this case, we instrumented to size 35 in all 4 canals. So the only instrument that's out on the tray is a 3504 rotary file. Okay, I'm just going to, once we get back into the core of the tooth, I'm just going to use that same rotary file, not the same exact one, but we're going to use that same size rotary file and just pass it through the 4 canals and then go into our disinfection and our obturation appointment. Okay, so or obturation phase. So this is why this is a pretty time efficient appointment, and it's chit chat and maybe 10 minutes of clinical work. But anyways, let's get right into it. So bite blocks in, and we're going to go forward with our rubber dam isolation. Okay, this is again a number 13A clamp, single tooth isolation. We just place it right over the tooth. This is some nice video footage of placing the rubber dam, and then we're going to use either our fingers or the paddle instrument to relieve the wings of the rubber dam material, and there you have it, rubber dam isolation in 5 seconds. Okay. And now we're simply going to be removing the temporary restoration, which in this case is our Fuji 9 glass ionomer. All right, so we're going to use a surgical length round burr, as we always do, size number 4. If you want to use a size number 6, you can as well. Size number 4 is what I use for the vast majority of my access preparations, unless we're dealing with anterior teeth. So we're simply just going ahead and removing that Fuji 9, and we're going to basically drop right into that sterile sponge. So don't worry about being too quick with this. You should just drop right into the sponge, which is going to stop you from progressing with your burr and doing damage from where you left off last time. So just going around circumferentially around the confines of where that Fuji 9 is inside the tooth, and we're going to eventually just drop right into where that green sterile sponge is. Okay, but if you have another color sterile sponge, sometimes we use yellow as well, but in this case it's the green sponge. And clearly I'm a little slow here because I'm messing around with the microscope and the camera for you, but this should be a pretty quick little step here to take out the Fuji 9. And if you had Cavit, it's even easier because it's a soft material, obviously. But I'd recommend using the Fuji 9 most of the time, just so you have a much stronger temporary restoration. They're less likely to dislodge it and thus need appointments to replace the temporary restoration. It's just a much better temporary. But you might get a little of the sponge that gets whipped up in the burr. That's fine, but just make sure that you regain entry just as you left it last time. So we're going with our sodium hypochlorite, rinsing out a lot of that calcium hydroxide that was placed at the last appointment. You can see it's white there. It's that white creamy material. It's looking good, and we're pretty much right back to where we started at the last appointment. Okay. And so Now we're going to go ahead and get our 3504 rotary, just like I mentioned to you, and take that to length in every single canal, okay, all 4. So there we have it, 20.5 in the MB. You can see that there's some calcium hydroxide on the file as I withdrew it from the canal. And then our ML, 20.5. Good. And then our DB, again, 20.5 millimeters. And this file should slip and slide all the way down to the apex without any resistance. Because remember, this already has been prepared to the same exact file. We're just basically removing any calcium hydroxide that's in there so that we can obturate the case. And now we're going to go ahead and move forward with our disinfection stage already. So again, lots and lots of sodium hypochlorite in all 4 canals. Good. And then our last canal there. And remember, in an effort to minimize the number of paper points you use, we aspirate out the solutions, okay? When we're done, utilizing it. So we place it into the canal, we pull back on the syringe and pull out the fluids, and then we only have to use 1 paper point per canal in, 99% of the time. There we have it. We aspirate it out, and you can see the distal canals are right on top of each other, indicating that they're completely merging. And now we're proceeding with our 17% EDTA, as we always do, especially in a necrotic case. All right, so we placed it in all 4 of those canals, and we're going to actually let that soak for 60 seconds. This is a critical component in a necrotic case, especially a case with a lesion, okay, because we want to make sure that all that smear layer is removed internally, and that we're performing a maximum level of disinfection so that we can get the apical periodontitis to heal and have a happy patient with a tooth that's going to last her, hopefully, a lifetime. Good. 1 minute. And then I'm just going to flush it with the EDTA again and aspirate the EDTA out. And again, you only need about 3 to 4 milliliters of the 17% EDTA. There's no need to fill up a whole syringe. It's quite wasteful, actually. So save yourself a few bucks and don't waste your materials, obviously. And then we're going back in with our final flush of sodium hypochlorite, okay? Half strength, as always, in all 4 of the canals. And remember, the 17% EDTA is going to remove the smear layer, expose the dentinal tubules, and then your final flush with your sodium hypochlorite is going to allow that disinfecting solution to penetrate into those dentinal tubules and really get a high level of disinfection. So there we have it. We are done with our disinfection, and we're going to go ahead and proceed with the obturation phase of the procedure, starting with the paper points. All right, so these are Pro Taper F2 paper points, as I use in most instances, as you already know. ML and then MB. And the dental assistant will actually pass me loaded cotton pliers with a new paper point. This way I'm not trying to grab them from the packet. We use 2 cotton pliers in each setup, and once I'm done with the cotton plier with the paper point, I hand it to the assistant, and then she'll actually hand me a new cotton plier loaded with another paper point. Same with gutta percha cones. And now we're applying our Brasseler BC sealer in all 4 canals. Again, really passive seating of that syringe tip in the canals, and you can see the distal merging canals are filling each other as I'm loading them up. Removing the tip from the sealer and dunking the cone that's pre-measured 20.5 millimeters before I seat it in the ML canal first, because remember, MB canals usually merge with ML canals. We want to seat the longer first always. And you'll notice that I'm using the 30 gutta percha cones, even though I instrumented to size 35. Remember, oftentimes with the BC sealer, it's relatively thick. You'll find that using the matching cone will not allow it to seat all the way. So we typically use one size down. And our MB canal, as I'm seating the cone there, you'll notice it doesn't want to go all the way to length. That's because it actually merges with the ML, just like I mentioned. Okay, so don't be upset if your MB canal, your MB root filling doesn't go all the way to length, because it's not going to go past the point where it merges the ML. And now we're seating our 30 cone into the distal buccal. It's looking good. I'm just needing to grab it and make sure that it's seated all the way. And then finally, we're going to introduce our last 30 cone into the distal lingual canal. And again, that's a merging canal as well. So that will not seat all the way. It's only going to be seated to the point where it merges with the distal buccal. All right, so you just want to take it to the point where it meets it. Then we're going to take our cone fit radiograph, as we always do, and there you have it. Our cones are seated all the way to length. It's a wet shot, as I mentioned in the last case demonstration, so there's already sealer in there, and this is going to represent as close as possible as to what the post-op radiograph is going to be. So I'm obviously very happy with this. You can see the mesial root fillings are merging there, and same thing with the distal root fillings, right? And once we've obtained that radiograph and we're happy, then we're going to go ahead and get our System B heat tip. Again, this is the Buchanan Fine Medium 08 tip. We're going to introduce it in, and we're going to start severing these gutta-percha cones right at the orifice level in preparation for our compaction. So it can get a little bit busy inside the access preparation here, okay? So you want to be careful that you don't accidentally pull out a cone from an adjacent canal. So, start wherever you have easy access and remove that cone, and then slowly, as you remove or you sever the cones, you'll have more room to work with. Just be careful to not accidentally pull out cones from adjacent canals because the heat tip, if it's warm enough, will melt some of the gutta-percha and actually pull out a cone. So make sure you're being very, very precise as to where you're introducing the heat tip, so that you can do this obturation all at once, okay? So when you first start in dental school, perhaps, you're taught to obturate one canal at a time. That is so time inefficient, okay? Just learn how to obturate multiple canals at once so that, you can be very time efficient and your patient is not, unnecessarily in your chair for longer than they need to be. And so now we're compacting our gutta-percha with our Buchanan plugger. This is the size 1, which is the red color, and it's the larger of the two sides. Remember, that's what I reach for the majority of the time. The big side of the red Buchanan plugger. And there you have it. We're going to make our fine finishing touches on our root fillings here, but our obturation is essentially finished. Now we're just rinsing out excess sealer and gutta-percha flakes from inside. And we're using a lot of water, blasting it with the air and water buttons depressed at the same time. And we're going to go just with, our Buchanan plugger and eventually with a paper point and maybe a cotton pellet just to clean up internally. You want to have a nice, neat, finished product here. But our obturation is essentially complete. And we already know this patient feels good because this is her second appointment. There's no problems. There's nothing that's going to change between the end of between when she came in for her appointment today and after. So go ahead and place your core buildup here, no problem if you elect to. It's only going to take you, 5 more minutes, and you have a nice area where that it's clean, you have a rubber dam on, there's not going to be any leakage of a temporary restoration, so this is a great time. Utilize the extra few minutes and perform your core buildup and do what you got to do. If you want to go ahead and start a crown preparation because you have time, by all means go ahead and do that, but the point is you have the flexibility, and I want you to be time efficient so you can really power up your endo game, power up your revenues, and just enjoy all the benefits that endodontics has to offer. And so I'm just, finishing touches here. Again, I'm not one to overly edit my case demonstrations because I want you to be fully aware as to what to expect in terms of how long to schedule your appointments, and also so I'm being realistic with you and you know what to expect. And sometimes I use the paper point just to remove any excess sealer there. So again, I'm somewhat of a perfectionist with this. And I'm placing the sterile sponge. In this case, it's a yellow color, like I mentioned. And then my Fuji 9, my temporary restoration, okay? So again, if you want to go ahead and place your core buildup, be my guest. This is such an easy case to do your core buildup. I would probably, no question, do it right here as opposed to doing a temporary and reappointing the patient. But there you have it. We're just going to use our glick to just shape the Fuji restoration, and we're done. This patient is very, very happy with the outcome. Our post-op film was taken after our rubber dam was removed, and we can see the root fillings are just like they were at the cone fit shot. No changes, which is exactly what we like, and we expect this patient to fully heal. We expect the apical periodontitis to heal over the next 3 to 12 months. We'll get this patient back for a recall appointment and to ensure that the bone has filled into that lesion. But we expect nothing short of that. And you can appreciate the nice smooth walls in our access preparation. A lot of that is accomplished with the endo zebra, but this is a prototypical case that I see in my practice that you can very easily treat once you've developed the confidence and the training and the knowledge to handle this, which is what this training program is intended to do for you. So there you have it. I will see you in the next lesson.